Everyone. Good afternoon, everyone, and welcome to today's board meeting, today's October board meeting, which is we're fast approaching the end of the year. And so I'm going to officially call the meeting to order and start with approval of the September 18th minutes. Can I get a motion?
Lincoln Asia, so moved.
Is there a second?
Ben Steffen seconds.
Any discussion or concerns about the minutes? Okay, all in favor? Aye.
Aye.
Any opposed? Okay, the minutes are approved, Michelle.
Excellent, thank you. Cynthia, did we have anyone sign up for public comment?
No, we did not.
Thank you, Cynthia. So next on the agenda is the update from Michelle.
Thank you very much. And I'll be brief today because you'll have a lot of presentations. We have officially started into open enrollment season, so that's really exciting. You'll get a full update on that. But what's great this year, we, of course, got everything loaded and ready and notices sent out by 1st of October. We run our renewals and 99% of our QHP enrollees that we have in the system were auto-renewed. So that's terrific. That doesn't mean they'll all effectuate. They may come back, select a different plan. They may not pay their first month's premium, but they all were able to be auto-enrolled, which is really terrific. And 74% of those that we had auto renew did receive financial assistance. So as we've talked about in the past, we are seeing more people utilizing Maryland Health Connection that don't receive any financial assistance. And again, what we hear from the field is from a consumer perspective and from a broker perspective, the ability to see all the plans side by side and be able to shop amongst all plans, even if they are not getting financial assistance, is a big benefit. So that's really good news. So you're going to hear a lot more about open enrollment coming up in the agenda. The other big news to share, and many of you may have heard this already, but if not, we will have a change in leadership of the Senate Finance Committee. So the two committees that the exchange works very closely with is the Senate Finance Committee and the House Government and Operations Committee. And Senator Griffith was a chair of the committee last year. She, congratulations to her, has a new job at the Maryland Hospital Association effective November 1st. And Senator Pam Vital will become the Finance Committee chair. So that's terrific. And we have we've known Senator Vital for many years, and so we look forward to working with her as we start in a new legislative session. On the federal home front, of course, as we are all watching, not having a House Speaker has really delayed some activity by the House. And so we're all kind of waiting to see what will happen with that. The next federal government shutdown is scheduled for mid-November. Most of the exchange activities that we do will be able to continue without any issue. In the past, when we've had a government shutdown, we did have some challenge with our consumers accessing or getting information from the IRS, particularly if there was a flag that was on their account for not having reconciled. But we have put in other processes in place and working with CMS to allow those consumers to at least continue to stay enrolled and be enrolled. So that's good. You're going to hear a lot more about Medicaid, return to normal. And again, that's been ongoing. A lot of the things that we put in place have really helped with that process. We just ran our new auto or ex parte renewals, which are auto renewals for Medicaid. And we saw the auto enrollment or the auto renewal number go significantly up, increase significantly. So that's right where we want it to be, which is really great. But you'll hear more about that in a bit. We have one not so new employee, Jenny Garrison, who was with us up until 4 years ago and took a 4-year hiatus, is back with us and returning to her role in outreach and our individual outreach program manager. So we are thrilled to have Jenny back, and you'll be able to see her if anyone is going to the Hispanic Health Access Roundtable tomorrow. You'll be able to meet Jenny there, refresh your memory with Jenny, but we're really happy she's rejoined us. We are in the process of recruiting for a data analyst position. This is a key role we've been really working on for a while to make sure we get it as we want that role to be, which will be important for our agency to be able to do some more data analytics. So that's coming forward. If anyone knows of anyone looking for that type of role, keep your eye peeled for that that job posting. And then just as a reminder to the board members, this will be our final board meeting of the year, unless there's a need for closed board meetings, which will come under a different invite, but this will be the last public board meeting for the year. So just to remind you of that. And with that, Chair Herrera-Scott, I will turn it back to you.
Thank you, Michelle. Next up, we're going to hear from Dr. Ryan Moran, who's the Deputy Secretary of Healthcare Financing and Medicaid Director for the department. And he's here to give us an update on Medicaid unwinding. Ryan?
Yeah, good afternoon, everyone. Can you hear me okay? Okay, good. Sound check is fine. Let me see if I can share my screen to show a presentation. Can you see that full screen on your side?
Yes, we can.
We can.
Okay, excellent. So thank you, Secretary Herrera-Scott, and Michelle, thank you as well. I'm elated to be here today to provide an update on the state of Medicaid redeterminations. And the first thing I want to say at the outset of this call is I just want to thank Michelle personally for her leadership and partnership in this really what is an unprecedented process for the Medicaid program, not just in Maryland, but as you all know, nationwide. I've been able to spend some intimate time, if you will, with members of Michelle's team and her staff, especially Alvina from the information technology side and Venkat on some of the changes that I'll discuss with you, and have just been so impressed and pleased with the partnership and the strong collaboration that our entities share collectively together in this process. So thank you for all of your leadership, and thanks for the board's stewardship of their work collectively with the Department of Health too. It's interesting as we approach today's conversation being in October, because what we will find ourselves in is this is about the halfway point of the Medicaid redeterminations process for Maryland. We are in month 6 of a 12-month process. What I want to do today is to provide an update on primarily looking at some data on how the process is unfolding about halfway through, and then also some history about where we have been with navigating some most recent issues related to some of our automatic enrollment and how we've pivoted quickly in partnership with MHBE on correcting of those particulars. I know that others from the department, and of course the secretary, have provided you with updates on the past about the Medicaid check-in campaign and the Medicaid redeterminations process. This is what I would call, and especially across the nation when you look at other Medicaid programs as well, but all of us collectively working on unprecedented outreach of members across Medicaid's program in every state. In Maryland, of course, that was developed in partnership with the department and the Managed Care Organization Association on a robust unwinding campaign that's multi-mediums, multi-modalities, television, radio, outreach, significant touch points with each members of MCOs, just a wide range of activities. And obviously with the key objectives is to encourage Medicaid participants to update their information and to generate awareness of the process of renewals beginning again since the public health emergency. It goes without saying, this slide, I also almost do not like to show it in public because it just does not represent the breadth and magnitude of outreach that has done both with organizations, community-based organizations, statewide sister agencies on ensuring that we are comprehensive in our approach of messaging about the Medicaid redetermination process. I mean, as you all know, states got to elect how they went about this process. They could do shorter time periods or they could do a full 12 months. Obviously in Maryland, our unwinding plan is for a full 12-month period, which is we arrive in month 6 of 12. Other states, as you may have seen in the news, most recently, the state of Arkansas had a 6-month redetermination process and just completed that this month. And we are in close correspondence with obviously our federal partners in this regard to monitor the state of unwinding with CMS, but then also with the National Association of Medicaid Directors as things have pivoted throughout the course of the process. To support our efforts, obviously the goal of the secretary and mine and Michelle's is that every single person who is eligible for Medicaid, we want to ensure that they're able to retain coverage. Our federal partners with CMS did release some federal authorities that helped us drive innovation and to ensure that we kept coverage for Medicaid participants in this process. We have over 15 federal authorities and disaster plans. They come in different flavors in terms of their magnitude and impact. We rank in the top 3 states of having the most authorities and protections in place to try to drive and support coverage retention across the country. Some of those that I've highlighted there that have been most helpful in the process by the numbers, but then also in partnership with the exchange, which is why I wanted to highlight them, include linking SNAP renewal and Medicaid eligibility. To date, and it's now part of an automatic process that happens, but in the first 4 months of unwinding, we saw more than 50,000 Marylanders being able to keep their Medicaid coverage by linking SNAP and Medicaid eligibility. Many of you will also know, I see Stephanie Clapper from Healthcare for All on the phone, who was instrumental in legislation in previous session on express lane eligibility. And the department is working on making the ability for Medicaid eligibility and SNAP eligibility to be linked permanently as part of an 1115 waiver process that will be implemented after the unwinding period in 2024, and we're going through the appropriate federal approvals to see that. But we've seen SNAP as a significant tool to ensure that people retain coverage. The benefit exchange helped us train, I think, more than 300 plus individuals from managed care plans to help assist enrollees to complete their renewal forms. And also the Maryland Health Benefit Exchange team has been instrumental in us in changing some of the ways that we do automatic renewal processes, including allowing eligibility for individuals that have had 0 or below 100% of federal poverty level to be included as part of our automatic renewal process. And Michelle just highlighted that is one of the reasons that we have seen a significant increase, especially in the course of when we look at upcoming renewals of those processes as we've been implementing that work. We also, in the midst of this, the same Federal Consolidated Appropriations Act, right, that started the Medicaid unwinding process was the same appropriations bill that had states to come into federal compliance for 12 months of continuous eligibility for children. And that requirement is for states to beat that mandate by January 1 of 2024. And Maryland, also in partnership with the department MHBE, accomplished that task in August. That went live, and that has also been a key tool of increasing also our automatic enrollment rate as well. I will say, as part of this, and what we are doing right now is in conversations with CMS as our federal partner and through the Association of Medicaid Directors, beginning to think, and obviously this is dependent upon federal guidelines too, but beginning to think which one of these become permanent flexibilities over the course of time, which ones have yielded success, which ones are worth keeping. Those conversations at the state and federal level are beginning to happen as we move into the halfway period of unwinding process. As we had thought from the beginning of this, we have sought out to ensure that not only is this a process that we want to ensure that we retain coverage, but I very much view this nature of this particular work of renewals beginning again to strengthen our enrollment and eligibility processes across the board. And we did find that some of those enrollment and eligibility processes, particularly as it relates to our automatic enrollment, which we call ex parte, we actually identified a compliance issue about whether the state was conducting renewals at the household level or the individual level. The primary concern on the difference of conducting renewals in that way was the different eligibility requirements related to income, particularly for children that are within households. So there was concern that children within households were not being picked up in the automatic enrollment process, and that those renewals should be conducted at the individual level to ensure that that happens. Maryland, this was identified with CMS. It impacted 30 states across the country. We were one of the states that responded immediately. And we took action in pausing all procedural terminations. And that's a term, I'll remind you, that's defined by individuals that receive paperwork, but we don't hear from them. They don't return their paperwork for the months of August, September, and October while we implemented system changes. We also did a retroactive look back on people, or particularly children, who may have been impacted by this review at the household level versus the individual, and reinstated, and we've already reinstated coverage for more than 5,000 children for a full year. And then most significantly, we were able to complete system changes, or the Maryland Health Benefit Exchange team and MD Think, both of our enrollment and eligibility systems, were able to change their systems to conduct those reviews appropriately. Those were fully tested and moved into implementation last month. I just want to pause here and say that that is no small undertaking to move in terms of the information technology for this particular switch. And so I'm really proud of the collective efforts of our eligibility and IT teams to actually move this into implementation. And to Michelle's point, we will see final numbers of this being used at the early month of October, hopefully within the next couple of weeks, and we'll be able to report on positive news, seeing those numbers increase. I included this just to say that all of our data is being posted on our public website at our Medicaid check-in campaign site. And what you will find here is data that we just posted through the end of September on our website this morning. I will note that in each cohort, as we've staged it out over the course of the 12 months, you'll find anywhere from 115 to 150,000 individuals per cohort over the course of the 12 months. Here in September, we had 117,000 individuals that were up for renewal. I will remind you, as we just reviewed, we paused procedural terminations for August and September, and that's taken about 20,000 individuals that we did not disenroll for procedural reasons, because we wanted to run them through the correct ex parte process. So when you look at these numbers, you can say that that number was approximately about 135,000 that should have been up, but we paused them because we did not hear from them. And then you can see we are closely monitoring really 3 key metrics as part of this process. First is coverage extension rates. So that's is just defined as individuals who are able to continue their coverage. Second is procedural terminations, a key metric that we watch and that's been highlighted across the country in terms of the news. And then third, the ineligible rate. But often that's one of the other mechanisms that we have in place for individuals that are deemed ineligible, primarily due to income in this process, is having an automatic enrollment process with the exchange for a qualified health plan. And Michelle and team are tracking those numbers closely as people begin to effectuate into premiums as part of that work. This is, that was just a 1-month dashboard and scorecard, and we post those individually. This is a chart that gives you the data for all the way through September for rolling numbers. So the state in this process, and this, again, this doesn't include procedural terminations for August and September, but we have conducted more than 638,000 renewals. You can see that our procedural termination rate without, so including individuals that potentially would have been procedurally terminated if we hadn't a pause, is about 16.5%. Just to give you context from a nationwide perspective, that number varies widely across states, but is around 23 to 26% on any given month. So we're certainly below the national average in terms of what we're seeing from other states. The last portion of the presentation, then I'm open to take questions. Is we are using data to pivot our outreach strategies. Obviously, the most important thing is that we ensure that we are guided by what we're seeing in terms of those procedural disenrollments. What we have done for the first quarter, May through July, there's some lag as we look to analyze the data. But we found about 60% of all people procedurally disenrolled are concentrated within 60 zip codes across the state. You can see those zip codes that are highlighted here. And you can see areas, of course, within Baltimore City, surrounding areas of Montgomery and Prince George's County. And then you've got some instances out in Frederick County, Allegheny County, Hartford, and then down on the lower shore. What we're doing as we look at this particular data with our MCOs as part of our Medicaid check-in campaign is we are revising both our media and our grassroots plan that we have attached to the campaign. Some examples of those revision of media plans based on this data is expanded print and digital presence in places like convenience and laundromat stores in these zip codes. We've added new rail light advertising, expanding radio buys with a specific emphasis on Hispanic radio in the Washington, D.C. area. We've also expanded bus shelter expansion in Hyattsville, Prince George's, and Silver Spring, billboard advertising in Hagerstown and Frederick. And across the state, what we've been able to do is expand our paid search in terms of online search terms that people use about Medicaid to ensure that people get access and are driven towards the Medicaid check-in campaign. We also have novel strategy approaches. You'll see us and the governor's ad that he completed for the department on apps like Nextdoor, streaming capabilities on digital presences. And we also, last week, you should see us if you go into your appointment for the Maryland Vehicle Administration. So we're on those particular digital signs. So every aspect in terms of blanketing the state about the work that we're doing. We also, as part of the campaign, in addition to all the outreach to community-based organizations across the state, have been working with two particular agencies, Cool & Associates, that's focused in on these zip codes related into Hispanic Latino outreach, and also Live Chair Health, who's really supporting a lot of different particular events, but concentrated in the Baltimore area in terms of the highest zip codes from a procedural disenrollment. What these partners do for us is that they allow us to take materials directly into communities at these particular events and be our boots on the ground in terms of spreading the word about the campaign. Michelle knows this, the secretary knows this, and so I will give my caveat is that everybody likes to ask us, well, how is Maryland doing in comparison to the rest of the country? And what I always say is, well, everybody's on a different timeline from a Medicaid program. And so it can be difficult to compare yourself, but that hasn't stopped anybody from comparing us from a state perspective. Probably the most trusted source that's being used in the national outlets is the Kaiser Family Foundation. They have an unwinding tracker. And also they take data that states are reporting. Some states are not reporting as publicly as we are. And that data is about a 90-day lag from CMS. So some of this will get updated and level itself out, if you will, for those states that aren't reporting but to CMS, and CMS is then reporting 90 days late. But what you will find here is that from a renewal rate perspective, coverage extension, and a disenrollment rate, Maryland ranks the 6th best in terms of this particular category. And another key metric that we watch in comparison to other states is, well, from all of the reasons, for the reasons that individuals are disenrolled, what percentage of those are terminated for procedural reasons? And in this particular category, Maryland ranks 12th best. This will likely change over the course of the next couple of months because states also that found themselves in the ex parte situation did pause procedural terminations. And so you'll likely see these numbers fluctuate over the course of the next 60 days, which is why I always say context is really important as you review these reports. But what I do think it does say is that for an unprecedented situation that we're all going through, we can acknowledge both that there's been a lot of work to date, and we can acknowledge that there's still much to do in order to ensure that every single person who's eligible for Medicaid in the state of Maryland retains coverage. So Secretary and Chair, I will turn it back over to you. I'm happy to take questions or receive comments from any board members at this time.
Thank you, Ryan. And I just want to add, if it's not readily apparent, this has been an incredible amount of work with all hands on deck. And as Ryan pointed out, it's not only everyone on his team, but certainly everyone at the exchange working together. So I want to thank Ryan and Michelle for all the work both our respective agencies have done to get the kind of results that you're seeing. And with that, before I go on to the next one, want to see if anyone has any questions for Ryan or for Michelle, quite frankly, on all the work that's been happening around redeterminations. Okay, thank you so much, Ryan. Thank you.
Yeah, take care, everyone. Thank you.
Bye. So next on the agenda, we're going to hear from Kathleen Bahrain and Sharon Merriweather on the board communication policy, or the proposed board communication policy.
Thank you. And what you're going to hear from me is me introducing Sharon, who will walk us through remembering the process, what we set out to do, the process that we've gone through, and then Sharon will walk us through the draft policy for consideration by the board. So Sharon, it's all yours.
Thank you, Commissioner. Am I sharing my screen now?
Yes.
Okay, great. All right, so I am going to present to you the proposed board communication policy. This policy was initiated by the policy committee, and I was tasked to kind of work on this policy, and we brought it back to the to the policy committee, I believe at least twice, and there were some revisions and some changes and a lot of good discussion. The policy was created really because there seemed to be a need to encourage and facilitate open communication among board members, with board members and staff, and also board members, had questions about what they could speak about publicly and if there were any rules for that. Because there wasn't a formal board communication policy, that's what we set out to do here. The objectives of the policy are here. It's to really make sure that there's accurate and pertinent information and it's given out in a consistent and uniform manner, that all board members have equal access to information, that the communication between board members and the management staff in particular is efficient and timely, and that the accurate, consistent communication reflects the views or the positions of the board as a whole. So there were some assumptions and principles that we put in place when we were working on the policy. And really, the main one is that MHBE is a public unit, and it is the public is interested in the business of MHBE. Also, that trustees are fiduciaries of the board and they have a responsibility in that respect. Also, understanding that erroneous information, inappropriate information, or untimely information is a risk to MHBE, and that, of course, there's a need for open communication. And that also brings into the Opens Meeting Act that, of course, this board is subject to. And we also realize that the ex officio members may need to speak out about MHBE or about issues pertaining to MHBE in their capacity as state officials. So there needed to be recognition of that in the policy as well. So the policy basically is broken out into three major parts. The first one is communication among trustees. And it generally says that the board is going to carry out all of its activities in the spirit of open government. And that entails the notices and agendas that are publicly posted, that if there's going to be a closed session, that those notices are sent out as well, that there won't be any secret ballots taking place, that we will encourage public comment when appropriate, and also that the trustees will be open, frank, and constructive during their meetings. Communication with MHC consumers is pretty basic, just that the trustees will refrain from giving explicit advice or counsel regarding insurance programs or plans purchased through the Maryland Health Connection, and that any questions about that MHC customers may have will be referred to the appropriate management personnel. Communication with trustees, with the MHBE management or staff, that's the second section there. And it says that the trustees will direct any concerns or any request from that they have to the appropriate resource or to the executive director as appropriate. And also that they will share any information regarding or that's pertinent to MHBE with the executive director. And the communication with external parties, it says that any communication should be consistent with trustees' fiduciary duties, that trustees will respect the decisions and policies of in any of the external communications that go out, that they will disclose when they're not representing MHBE or its opinions or approved positions, and that trustees won't disclose any confidential communication, of course, and that the board can at any time delegate a specific trustee to speak on a matter that's of interest to the board. And then communication with the media states that no unilateral communications or commitments on behalf of the board will be made, and that the chair or the chair's delegate will act as spokesperson for the board. Staff will write written press releases, and that has been the practice and will continue to be so. And that trustees may write articles, but they should be reviewed by management before they're published. And then, which everyone is already familiar with, but we just put here in writing that protected information will not be disclosed by trustees, and that would include consumer records or personnel records, and obviously not limited to that, but those are the main ones that the trustees may come in contact with. So with that, there will be a resolution if the board agrees to approve this policy. And that can be read by the secretary. And also, I also mentioned here that the policy would be reviewed every 3 years. Are there any questions that I can answer?
So, may I?
Please.
Yes, go ahead.
So, and I agree, you know, that there should not be a series of communications among, you know, which are in violation of or in lieu of having a meeting. But if two trustees happen to be having a discussion on a subject matter, like one discussion, is that also considered a violation of this? Or, you know, if I saw Ben somewhere and Ben and I are talking about something, as an example, the only reason I took his name, his picture is next to mine on the screen. And will that be considered in violation of this?
No.
It's not a series of meetings and stuff, or is that can be okay?
That is okay. And really, this does not limit the board members any more than the Open Meetings Act does. And that would not be a violation of the Open Meeting Act because it's not a quorum of the trustees in that meeting. But I will say that what would be considered a series of meetings is if the same trustee talked to one board member about the subject and then to another board member about the subject and was really trying to get their perhaps vote on a matter, and then you come to a meeting and everyone has, even though it's one person, everyone has already decided what they're going to vote, and there's no discussion, no frank discussion during the meeting. That would be a problem. But if there's a discussion between two trustees that is not a violation of the Opens Meeting Act or this policy.
Another question, and that is, we have some subcommittees, and from time to time, the subcommittees, in order for them to conduct their business, have a need for information which does not necessarily requires to go to the entire board, because the subcommittees in the process of conducting their business, it may eventually come to the board if it gets to the subcommittee. So I think there needs to be appropriate provision for that. And I saw somewhere the mention of that, but I did not see it to be that clear. And the second concern I had was that if there's a need for communication, that it has to go through the executive director. And my concern on that one was there has been times when that has been a barrier. That's one. And then the second is the compliance officer has access to the board, and there could be time to time communication between a board member, especially if it's a finance and audit committee, and the compliance officer, and that should not have to go through the executive director if that poses a not free flow of information between the two parties.
Thank you. So I'm not seeing specifically in here where the concern you had regarding everything going through the executive director. I think the one thing I see here, it says trustees will direct concerns or questions concerning any aspect of MHB operations to the attention of the executive director or other appropriate member of senior management. Does that not answer your concerns there?
That would, if that communication in that example does not have to go through the executive director, if it may pose a conflict, then I'm okay with that.
Yeah, Singh, I would also mention that none of this alters the existing bylaws or any of the other committee structures. So what this does is it, if anything, it kind of fills in the blanks for communications that are not, for example, part of the committee work or the subcommittee work, or otherwise addressed in the other policies of the board. So there would be nothing about this that would force someone to go through the executive director in a circumstance where, although I'm not aware of this ever occurring or ever expect this to occur, there would be a reason not to share it, right, with the executive director because of a conflict. So I believe, and Sharon can correct me if I'm wrong, but there are other protocols and procedures, policies that would kick in those circumstances. And obviously the bylaws are always supreme.
Yep. I mean, I don't have, and again, that's in any corporation, that is where, especially when it comes to audit and finance and compliance, that there needs to be those options available. And I don't have an issue in those cases. The council can be present, because you always want to protect the organization and have protected information. And again, I'm bringing it because this is the way most boards and the corporations function.
Thank you. And I will say, I do agree with the commissioner in her words, and the policies really supplements what we already have out there. It doesn't override any of those other documents.
Thank you.
You're welcome.
Any other questions? So Sharon, just for clarity on my part, I can read the resolution so we can then vote.
Yes.
Okay, great. Thank you. So this is a resolution of the Maryland Health Benefit Exchange Board of Trustees approving the communication policy. So whereas the Board of Trustees of the Maryland Health Benefit Exchange strongly supports the need to encourage and facilitate open and effective communication among the trustees and between the board and management, committees, staff, and external parties. Whereas it is the expectation that the board receives accurate and pertinent information in a consistent and uniform manner, that trustees have equal access to appropriate information, that board communication is efficient and timely, and that communication with the management and other parties is accurate, consistent, and reflects the views or positions of the board as a whole. Now therefore be resolved that the Board of Trustees hereby adopts the Maryland Health Benefit Exchange Board of Trustees Communication Policy, which was attached in the packet as Exhibit A. Can I get a motion to approve? Or do we just take a vote, or Sharon, what's the process? I mean,
So, yeah, you don't need a second, but you just, everyone needs to vote in favor or against.
so do we go one by one?
We can see where we are here. You can say all in favor and see.
All in favor?
Aye.
Any opposed? Okay. We have approval of the policy.
Thank you.
Thank you, Sharon. Thank you, Kathleen. So next on the agenda, we're going to hear from Becca Lane to hear about race and ethnicity question revision. Becca?
Hi, everyone. My name is Becca Lane, and I am the Senior Health Policy Analyst on the Policy and Plan Management team under Johanna. So I'll just give Cynthia a second to pull up my slides. Great, thank you. We can move ahead to the first one. So I'm really excited to bring this information to you guys today. Yep, that's the first one. Thank you. So we are working on a project to improve our race and ethnicity data collection at MHBE. And so I'm going to give you some information on how that's been going and our next steps. So first off, just for some basics about race and ethnicity data, we collect this data on, Cynthia, everything okay? Great, thank you. Oh, I'm not sure what's going on with the slides. They appear to be scrolling back and forth for me. But anyway, I guess I'll just keep going with the basics here. So yes, we collect this data on consumers on the application, and that data is transmitted to insurers at the time of enrollment and used for tracking enrollment trends, setting targets, and informing outreach on particularly communities that are disproportionately uninsured. And so this is an important piece of information for us to be collecting because it's what helps us track our progress towards health equity goals. And another piece of background that's important to know is that there are federal standards for how this data is collected. The Office of Management and Budget and the Department of Health and Human Services set some standards for this data collection. So particularly they dictate which main race categories we have to collect. And then also they specify that we shall not force anyone to disclose their race and ethnicity data, which makes sense. All right, next slide, please. So in 2021, the policy team at MHBE facilitated a health equity work group. And one of the things that the work group focused on, because it kind of underpins all the other work we are able to do, is this issue of collecting race and ethnicity data. Without good data, we won't be able to track our progress with on any of the other ideas that we talked about in the work group. So at the time that we discussed the race and ethnicity data in the work group, the questions were optional, and 35% of respondents or applicants did not respond at all or just selected other, which doesn't really give us any meaningful information about them. And like I mentioned, the low response rate limits our ability to meaningfully interpret that data. And then we also found that response rates really varied by consumer assistance type. So in particular, brokers had a really high rate of skipping the question or just responding other. And in the process of looking into this, we heard a presentation on best practices from America's Health Insurers group. And then we also learned from New York, which had already embarked on a similar project. So they were able to give us some advice. And then we received some technical assistance also from this group called the State Health Access Data Assistance Center. It's been really helpful. So next slide, please. And ultimately, the best practice revisions that we discussed and then implemented included the following. So firstly, the questions are no longer optional, although we are still in compliance with federal standards because we have added a prefer not to say option in the answers. We also have added explanatory text because it's been shown that when people understand why they're being asked to provide this data, they're more likely to provide it. We've added some more answer subcategories, so people are more likely to find an option that they identify with, and we developed the subcategories by looking at Maryland census data and picking the groups that were most populous. So this is something that we're going to look at in the future because it's tough when we can't put everyone's identity on there because it would make the question too unwieldy. So we have to choose a smaller select list. And so it's really kind of an art and a science to figure out which ones we should choose, because it's not necessarily the case that only the most common identities are the ones that we want to collect the most information on. Sometimes we want information on smaller groups, and that doesn't necessarily come up if we're just looking at census data, but it is where we started, and it's a good start. Lastly, and this part is really important, we worked with our consumer assistance workers and call center staff. We briefed them on the goal for the new question and gave them some instructions on how to ask it. And ultimately, all these improvements were launched at the end of April of 2022. Next slide, please. So just quickly here, this is the original question, and you can see we just had simple yes or no for the Hispanic Latino ethnicity question, and then a list here of all the options that we had before. Next, please. And now you can see how the question looks now that we've made a bunch of adjustments. So as you can see, there's a little asterisk that indicates these questions are required, but you can see also we have prefer not to say under both the Hispanic Latino origin question and the race question. We've also added a I only identify as Hispanic or Latino question, which or answer option to the race question, which was actually a good move because we are seeing a lot of people choosing this answer. So this is something that we weren't capturing with the old question format. And then, of course, in order to adhere to federal reporting requirements, we have ways of rolling that up to one of the standard categories that they want us to collect. But for us, at least, we have this insight. And then you can see we have the answer options with drop-down lists underneath the main race categories. We've also added a Middle Eastern North African category, which is not required federally, but again, is something just for us to know. And then you can see that other at the bottom. So there's ways for people to opt out, but it is more likely for people if, you know, if they would have skipped it before, but now they have to provide a response anyway, they may choose to actually give that information rather than just skipping. So next, please. So as you can see here, we are seeing an improvement in the response rate, which is great. So the blue in 2022 is lower than the response rate in 2023, which is in red, 9 percentage point increase in race response rate and 5 percentage point in ethnicity response rate. So it's already working, and we're really glad to see that. Next, please. And you can also see that by assistance type, we're also having an improvement in the response rate. So for, and in particular, brokers, you can see that the response rate has jumped quite a bit. And so we're already having the intended effect. And some of the other categories, the increase in response rate is a little bit more modest, but it's still an increase, which is good. And then you may see here that the caseworkers saw kind of a drop off in the response rate, but we have already looked into that, and we've identified that it's because they were not required to take the same training that the other consumer assistance workers are required to take through MHBE. And so we've connected with the appropriate people so that we can get the caseworkers the same briefing on the new question. And we're hoping that the next time we take a data snapshot, we'll see an improvement. Next slide, please. So as I've kind of already alluded to, we already have in mind some, or already have embarked on some next steps for this project because it continues to be ongoing. We are identifying other opportunities for more consumer assistance worker training, like I just mentioned. We are also looking at a procedure for adding or changing response options. There is also an opportunity for us to establish an agreement with CRISP, so the Health Information Exchange for the state, to improve race and ethnicity data completeness. So CRISP houses electronic health records data. So what we can do is, if we have a partnership with them, we could possibly impute their race and ethnicity data from health records into our application data. Just overall, we're going to keep using this data the way we have been, but hopefully with even better results because of the higher rate of completeness. So just continuing to track enrollment progress over time and using that data to drive our outreach and enrollment efforts. So that's the content that I have for you today. I'm happy to take any questions.
Thank you, Becca. I actually have a question. So, just looking at slide 7, when you're talking about the increased completion rate for race and ethnicity, can you say more? Because if the answer is prefer not to say, and it's just completing the question, but you're not learning anything more, even though they're completing the record. I mean, are we getting better data, or the prefer not to say bucket is increasing, so you still have a 35% or a high rate of really not understanding why people are choosing not to answer some of these questions?
That's a good question. I can speak more to how I've analyzed the data to give you kind of an answer to that. So the way that I'm measuring it, or the way that I've presented it in the slides, is unhelpful data. So how do I say this? So instead of just saying, because we don't have a non-response rate technically for the new question because people can't opt out. So what I've done is compared the answers before that included both no answer at all and other, comparing that to people who answered other and prefer not to say or do not know or something on the new question. So it is technically a comparison, and it is indeed showing that that the amount of unhelpful data that we get is reducing, if that makes sense.
So prefer not to say is helpful in that the person prefers not to say, but it's not helpful in helping to identify race and ethnicity, right? So that's the question I'm trying to get answered. So do we know any more about the population based on the updates to the questions and the way we're asking them?
Let's see.
And maybe I can also jump in. Cynthia, if you could go forward one slide to the graph. So I think what Becca was trying to, back to just the one with, there we go. This is just comparing response rates where we got a meaningful response, where someone selected a race or ethnicity. So the kind of inverse, we look at ethnicity, so we got white or non-Hispanic or Hispanic, and then in 2022 20% said other or didn't answer, and then in 2023 15% said prefer not to say. So this is the bars are representing the truly helpful, the truly detailed responses that we got.
Johanna, you were breaking up a bit, so I might
I got
just.
it, Michelle.
You got it? Okay.
Yeah, I got it. I heard enough to understand what you were saying, so thank you. Any other questions for Becca?
What's best in class? Like if we were firing on all cylinders to collect this type of information, how close are we to best in class?
It really varies, but I think when New York did this, they were able to get up to like around 80%. And so if we can get a little bit higher as we keep going with it, that would be great to see. So we're on the way, not quite there yet, but I could also look into more specifically where we fall compared to other states in terms of collecting this data.
And then is it a once and done, or is there or as part of the protocol and engaging, do we go back and ever ask the question again, or it's only at enrollment?
Yeah, that's a good question. So when people go into the MHC portal, if they haven't given that information in the past, part of the implementation of the new question was there'd be a prompt when they sign in to say, you know, would you like to update this information?
Any other questions for Becca or Johanna? Okay, thank you for the update, Becca.
Thank you.
So next on the agenda, we will hear several updates regarding open enrollment readiness that'll cover overall goals, technology, consumer assistance, and marketing outreach. So we'll start with Andy Ratner, Chief of Staff.
Well, thank you, Madam Board Chair. Good afternoon, board members. I'm Michelle. I'll go over some of our goals, strengths, and challenges, and then hand it over to Elvina and Tamara and Betsy to talk about how we'll achieve those. Next slide. So there's 5 goals for the upcoming open enrollment. Number 1 is to grow enrollment. The uninsured rate for the state, the last available was 6.1%. The exchange is only one piece of the puzzle. One way to know that is we have grown enrollment for 5 years in a row, and we're still at 6.1% overall of the state, because other parts of the puzzle, from employer-sponsored insurance to other forms of public insurance, can fluctuate and have a big impact. But our job is to do all we can to make sure people have a place to go if they don't have coverage. Number 2 is to reach target audiences with higher levels of uninsured, historically higher levels. And that includes a Hispanic population where the uninsured rate is over 20%. It was once almost 40%. So we have also brought that down, but still much higher than the general population of 6.1%. The uninsured rate for the Black community is 6.5%. And young adults, as we know, are another big component of the uninsured in Maryland. They comprise about 1/3 of all uninsured adults in Maryland, according to the most recent figures from the Department of Health at the federal level. Number 3 is to reach the Medicaid unwinding population that Ryan had talked about. Next slide. Number 4 is to grow throughout the state, especially the lower shore, Western Maryland, and Baltimore City, with higher percentages of uninsured. And these are the most recent at the county level that were released from the Census Bureau. And you can see Caroline over 9%, Wacomico almost 9%, Dorchester, Kent, Worcester, Talbot, Garrett, Baltimore City, all above the state level of uninsured. So those are areas where our outreach and our marketing is going to try to drill down to make sure we get to as many people as possible in those areas. And the 5th goal is to grow in Montgomery and Prince George's County, where the uninsured rates are respectively in Prince George's 10.8% and Montgomery 7.3% in the most recent figures available. And the population is so large in those 2 suburban DC counties that they account for nearly 1/3 of the total uninsured in the state, according to our analysis. So those are the 5 goals that we have for this open enrollment. Next slide. Our strengths heading into this open enrollment, more carriers than any year since 2016. Aetna joins Care First, Kaiser, and United Healthcare in the marketplace. Secondly, it's our third year for the additional state subsidy for young adults, and we've extended the parameters from 18 to 34 years old to 18 to 37 years old, and that we think that's already begun to make a difference in the first 2 years of that subsidy. And thirdly, it'll be the second year of live chat and Broker Connect, and the first year of live chat directly in the application, and those are popular, speedy assistance features online that have done a lot to improve consumer experience with Maryland Health Connection. Our challenges include the Medicaid unwinding during open enrollment, which will add opportunity, but also volume and complexity for consumer assistance. And lastly, we're as the rates approved by the Maryland Insurance Administration recently, we have still the lowest, least expensive plans in the nation. But unsubsidized consumers will see an average increase of 4.7% for 2024 for a very price-sensitive product that is health insurance. Are there any other questions you have before I turn it over to Elvina?
So, Madam Secretary, Dr. Herrera Scott, I have a question.
Go ahead, Ben.
So going back to the counties, if you could scroll back maybe 2 slides. The Montgomery County one and Prince George's. So I'm thinking that this is slightly different sources than, although you are referencing the same one. If we're overall state unemployment uninsured rate is 6.1, something doesn't quite add up to me, given 3 of the 4 largest jurisdictions are well over the state average. Is this a different data source maybe?
Yes, it is a different data source. It's the small area health insurance estimates from the U.S. Census Bureau, and they have not completed the more up-to-date one. So this may be with 2021, at least a year or 2 years earlier than that. So
Okay. Yeah. All right, yeah, that's worth noting, because it'd be hard to have a uninsured rate of 6.1 with Montgomery and Prince George's and Baltimore City all above the state average. Thanks.
All right, I'll turn it over to Elvina.
Good afternoon, everyone. Today I will be providing an overview on key initiatives that we have or key activities that we have for this open enrollment readiness across various functional units within IT, and also what's new or what new system changes we have implemented for this open enrollment, especially benefiting consumer and broker experience. So in this slide, as you see, leading up to open enrollment, we had our plan validation and upload, which was completed on 9/21 for the individual marketplace. We had our 2024 plan load completed on the small business side as of 9/30. As Michelle mentioned, we had completed our QHP auto renewals by 10/1 and notices were sent to consumers. And this is the highest success rate that we saw compared to any other year so far from the QHP auto renewal perspective. Our plan shopping preview was open to consumers as of 10/5, even though it was available for carriers and others to review, so that we give enough opportunities for them to look at the 2024 rates to ensure everything was loaded correctly in the system. Also, we had a major release implemented as of 9/29, and as Michelle and Brian mentioned earlier, one of the key initiatives that was implemented was ex parte renewals at individual, which was a huge change for us from the way we did Medicaid renewals before this change was implemented. We do have a release as of 10/20 scheduled for this month, focusing primarily on the open enrollment related changes. And also one of the key initiatives that we're looking to implement on 10/20 is an alternate login mechanism that we want to provide consumers this open enrollment. Our open enrollment, as you see, is from 11/1 to 1/15. After the release on 10/20, we kind of go into code freeze. However, we will be having hot fixes if necessary, if there are escalations and any issues that come across. We do have catch-up renewals as of 10/30, which is for any new consumers who come between our auto renewal and between 10/1 to 10/30, and they have shopped for 2023 plans. We want to ensure that we crosswalk them to a 2024 plan before the open enrollment kicks in. We do have a catch-up renewal scheduled as of 12/14, and that's for any consumers who have shopped for 2023 during open enrollment, and potentially they have been in the process of plan shopping for 2024 and have not completed their shopping for 2024 at that point. Also, we are having post-open enrollment tasks, which we do always on an annual basis, primarily to ensure that we have all these CMS reports and other open enrollment related metrics ready for our stakeholders for review. Next slide. Thank you. So in the next two slides, I'm going to talk on some of the open enrollment readiness across various functional units within IT. We have command center that is going to be set up and up and ready for open enrollment, which we are already in process. We have our stakeholder communications in place. We open up a bridge on the first week of open enrollment. So if there is any incidents, any escalations, anything that the field is reporting, we want to make sure we have a rapid response for all those escalations. So anyone can tap into that bridge, whoever has that information, and they can report incidents there. And then from there, the information is dispersed to appropriate teams so that they can take action on those incidents and make sure the system is up and running. They also do system performance monitoring, so which is already in place, and we have started the mock run as of last week, and we also did the scale up of servers in ready for open enrollment. So we have our capacity plans and other things also ready for this open enrollment. From carrier management perspective, we have been actively working with our carriers in the past several months, and one of the results of that was the higher success renewal rate. We worked closely with them to reconcile our QHP policies and get the most up-to-date effectuation information in the system aligned before our auto renewals was run. Also, this time we worked closely to make sure the plan upload was done on a timely manner. And that's how we were able to have our plan loaded, completed by 9/21, and the plan shopping preview open for the consumers as of 10/5. Next slide. Also, some of the other areas that we are ready for this open enrollment, especially from the system changes, we made sure some of the feedback that we got from last open enrollment, especially on the user experience or performance related improvements that we could do, we have made sure in various releases we have implemented and we have completed those changes. As I stated earlier, we have one more release this month, and that should complete all the system changes that we have planned for this year. On an annual basis, just before open enrollment, we have extensive open enrollment readiness testing that we go over. We perform all kinds of open enrollment checklist, and we make sure the system is functioning in each of the units and make sure extensive regression testing is performed so the system is up and ready and good to go on the day of open enrollment. We have various CMS reports that we submit during open enrollment on a weekly basis, especially the CMS priority metrics and expanded metrics towards the end of open enrollment. We also have dashboards and ClickSense and some of the other reports that we share with our stakeholders on a weekly basis. So we are already prepping towards those reports. We have updated to include our new carrier this year, Aetna, to ensure all the reports reflect those enrollments as well. Lastly, but not the least, we have all our resources aligned and assigned for various tasks this open enrollment. Next slide. All right, so I'm going to touch base. We have implemented so many changes this year, but I'm going to talk on few changes that benefits the consumers, especially their experience in the portal. So the first one, last year we implemented live chat feature, which was open for anonymous users. They could come and connect with a live chat agent, but earlier this year, we implemented live chat for logged in users. So if they are in their application at any point, if they have issues, concerns, or they're unable to proceed in the application, they can start a live chat with the chat agent and they're able to get the response immediately. And we have seen during the PHE unwinding period, the live chat sessions go up, and we're seeing about 1,000 chats per day as of what we saw in the past several weeks. This year, another channel we opened up for consumers to seek technical support was secure messaging. And at this point, it's limited mainly on the technical support. So it's pretty much if they have issues proceeding in the application in certain sections of the application, they can go and report the problem, which then creates a case in Salesforce. And there is a team who looks at that on a daily basis, and we are able to resolve the issues, escalations that they provide within 2 to 3 business days. And we are also seeing a higher volume due to PHE unwinding on this, about 100 cases per day, and it's been resolved in 2 to 3 business days. Earlier, I stated about alternate login option that we are going to introduce, and this is not implemented yet. This is going to be implemented as of 10/20 release. This is primarily for users. What we have seen in the past is there is a high volume on the reset password, which is coming to the call center. So we want to ensure consumers have self-serve option, which is available so they can reset password on their own, which is already there in the system, but we are also providing an alternate option going forward that they can, if they do not remember certain password, they are able to just provide their email ID, and then we send a link to their email ID, and then they can provide that one-time passcode to proceed to their account, and then they are able to navigate to reset their password, so that so we potentially could reduce the volumes going to the call center on this particular escalation. The other thing that we implemented this year for this open enrollment, as Andy mentioned earlier, was expansion of young adult subsidy. So we did see with QHP renewals itself, the young adult subsidy utilization was higher. That's because we expanded the age from 34 to 37, and also the amount of the subsidy that young adult population could receive is also a little bit higher than what they would receive in 2023, sorry. Next slide. One of the key initiatives we implemented earlier this year in regards to PHE unwinding was the Easy Enrollment Program for applicants moving from Medicaid to private health plans. In this particular initiative, whoever would lose Medicaid coverage, and if they had, and we know potentially that they are eligible for private health plan, we would automatically enroll them into a plan. And after that, they would receive a notice and they would have to make the payment to be active in coverage. This would reduce the coverage gap for the Medicaid applicants, so that they would not have a gap in coverage before they really come back into the system, and they are able to change plans, or they want to get back into Medicaid, they're able to do that as well. But to ensure there is no gap in coverage, we implemented Easy Enrollment Program for them. The other key thing that we implemented this year was QR code in all our notices. So the consumers, when they receive the notice, they're able to scan the QR code and that would take them to the MHC website. We also implemented QR code with brokers, which I'll touch base in the next slide. And last but not the least, we have a new carrier onboarded this year. With that, we had to implement a whole lot of system changes to ensure their plans were correctly being loaded and their provider directory information was uploaded correctly in the system. And we also had extensive testing with them on the EDI 834s, 820s, SPMI reconciliation processes. So we are looking good with the Aetna carrier. We completed most of the implementation readiness with them for this open enrollment. Next slide, Cindy. All right, from the broker community perspective, the biggest change this year is the brokers have a mobile app, both in iOS and Android. Last year, they were able to help consumers through the desktop portion of the application and also through Broker Connect program, which we implemented last year. This year, they are able to help consumers using their mobile app. All the features that were there in the desktop portion is also available in the mobile app as well. In addition to that, for the Broker Connect program, we implemented something called Set Your Availability Times, which allows them to give a little bit break, even though the Broker Connect program is open from 8 a.m. to 8 p.m. or whatever the time frame we define. They are able to set I'm available 8 to 12 and then 2 to 4 or whatever their availability is, which then accordingly the referrals would go to the brokers who are available during that time frame. One other enhancement that we did with the brokers is the consumer could search for a broker who speaks Spanish. So that way the client search capabilities were enhanced as well. And that would connect to a broker who would be able to help them in their preferred language. That's all I had. Before I hand over to Tamara, if any questions, I'm happy to take them.
I had a question. You had mentioned that the largest number of calls we receive or requests for help had to do with the password reset. And now we provide that information on the email. So are we using a dual authentication process, or is it using just the single send me an email, I'm sending you a password? Because that's where recently biggest cybersecurity incidences have been related to password reset, and how protected is our own website and data from that kind of a malicious attack?
That's a great question, Singh Taneja. One of the things, even though we send one-time passcode in the email, we also have a lot of other security controls in place. The first thing is that email that we send the passcode has to be a verified email. If the email in the account is not verified, they will not be able to use this functionality. The second piece to that is once the passcode is sent, it's not just the passcode, they also have to provide their last 4 digits of SSN and date of birth, and that goes against our database. We match against that consumer's record. And also the SSN, the last 4 digits, even if we find a match, the SSN has to be verified in our system. Only when all these conditions meet, that's when they are able to log into their account.
Thank you very much.
All right, if no other questions, I will hand over to Tamara. Thank you.
Thank you, Elvina, so much. Hello, everyone. Next slide, please. Open enrollment period 2024 plan year. Our website opens at 5 a.m. on November the 1st, 2023. It closes at 11:59 p.m. on January the 15th, 2024. Enrollments through the month. So you must enroll by December the 31st to receive an effective date of January the 1st, 2024. Anyone who enrolls between January the 1st and January the 15th will receive an effective date of February the 1st, 2024. 99% of our QHP enrollees are auto-renewed, and with 74% receiving financial assistance. Next slide, please. Just a visual so you can figure out who our consumer assistance workers are. We have the call center, application counselors, insurance brokers, and navigators. I like to call them my boots on the ground. These individuals are in the communities and out there trying to help individuals get signed up for health insurance. Next slide, please. Broker operations. So I'm going to go off topic because these numbers have been updated just since a week since we sent you the slides. So there are currently now 1,229 current authorized brokers, and that's versus the 959 this time last year. Currently, we have 64 new brokers in training, 48 new applications for brokers, 157 brokers are participating in the the Broker Connect program. For all of you who don't know, Broker Connect program is an online referral system which connects a consumer to a broker in real time during normal business hours. We have 43 brokers this year participating in the BAT phone, and the BAT phone is a relationship. So if you don't already have a relationship with a broker, this transfer will allow you to get a relationship with the broker and get connected with the broker through the call center queue. Our outreach plans for brokers are renewing from assisted qualified health plans to unassisted health plans. And we've had extensive training. We had a really big training just last week where a lot of brokers attended, and we were able to give a lot of the new brokers systems training and how to navigate through the system. And they were really happy with that. Next slide, please, Cynthia. Application counselors. We have 206 certified application counselors, and this is up from 188 last year. There are 43 AC organizations versus 36 from last year. We have 7 new application counselors that are in training. Over 300 managed care organizations staff were trained. I think Dr. Moran reported on this. 300 were trained to go through and help the consumer get be able to stay in Medicaid and get assistance through the Medicaid eligibility during the PHE unwinding. Next slide, please. Connect Your Entity program. So this is where I'm really happy to report we have over 100 navigators who are participating this year, and this is a 15% increase from last year. And this was due to a few modifications that we made with regards to the allocation of funds and different stipulations we put on the navigators. Navigators will be assisting in person and virtually. The CEs are hosting 25 plus events, and this will be during open enrollment throughout the state of Maryland. Intense outreach to the uninsured and the high focus areas. Continue to help PHE unwinding and Medicaid redeterminations during open enrollment. Next slide, please. So I just wanted to highlight some of the focus areas. I think we've already talked about this. Andy went over this a little bit. These are the high focus areas that we found. This information is a little bit, maybe like a year or two old. It takes a time for the information to update itself, but these are the high focus areas that we're focusing on for 20. I think we're going back. I'll keep going. These are the high focus areas that we're focusing on for 2024. And we have boots on the ground in these areas to help individuals get connected and set up with health insurance. Next slide, please. Okay, connector entities. We have increased our bilingual capacity for our Spanish speaking consumers. We have established an outreach center that offers food, clothing, and referrals, in addition to assistance with getting people enrolled in health insurance. We became partners and established with a lot of school systems in high demand areas, allowed staff to be trained and certified among community health workers. This was a favorite of mine. This goes and actually allows individuals who are not actually connected with the connector entities be able to come certified application counselors or certified navigators and help individuals get enrolled. Hosting events at locations where people gather, restaurants, libraries, and schools. Next slide, please. Just want to go over some very important dates for everyone. General operations for the call center from November the 1st, 2023 to January 15th will be Monday through Friday from 8 a.m. to 6 p.m. every Saturday. Normally we just do open enrollment, but because of the PHE unwinding, they will be open every Saturday from 8 to 2 p.m. Just want to go over some critical business days. So because you have to get a January the 1st date, you have to enroll by December the 31st. So we're December the 30th and 31st are some critical days that we will be open, and that will be from 8 a.m. to 2 p.m. January the 13th and 14th, Saturday and Sunday are some additional critical days. We will be open Saturday and Sunday from 8 a.m. to 2 p.m. And MLK Day, we will be open from 8 a.m. to 8 p.m. because this is the last day of open enrollment and we want to make sure everyone gets in. Closing holidays will be Thanksgiving, Christmas, and New Year's Day only. Next slide, please. The Consolidated Service Center. Open enrollment, recruitment, and training has ramped up. Extensive training is going on, trying to get 300 plus CSRs after training, testing, and nesting. We have conducted large training classes with multiple trainers. Special classes of Maximus employees have came over to assist from New York and Indiana. And some of the goals we're pushing to for open enrollment is for the call center to maintain 320 CSRs during open enrollment to manage the Medicaid unwinding and the open enrollment call volume through October 23 to January 2024. We're also running refresher training classes. So my training department will be reaching out to supervisors and leads of the call center. And we're going to be doing training to make sure they have up-to-date knowledge. So when a CSR is on the phone and they need assistance, the supervisor and the lead will be able to give them the help they need. That's really important to have that help in real time. Efficiently manage escalated cases. My deputy director, Wanda Oliver, has taken sole focus of escalated cases now, since now we have training in a good direction, and they will be managing the escalated cases in real time. Maintain low rate of attrition and absenteeism is a big thing that we're working on with the call center. Myself, Leanne Sapp, we're working with the call center to make sure people are staying, to make sure they're tracking and looking into why people are taking off. Do I have any questions? If not, I will turn it over to my colleague, Betsy. Thank you so much.
Good afternoon, everyone, and thanks for having me. I just wanted to let you know a little bit about the marketing and outreach strategy for open enrollment this year. I'll be going over some highlights of our market research, what we're hosting, and as well as the community events we're participating in, our media buy, and I'll show you a glimpse of our TV spot. So first of all, like we do every year, we did some market research. We used Eureka Facts, who conducted a survey of Maryland adults to learn about their experience and interest in health insurance and the risks they're willing to take in general, and also decisions regarding getting health insurance. So we found that the audiences of interest were people who have been in the cycle of health insurance the past 2 years, and the reasons they stated for being in that cycle of health insurance decision-making were general loss of coverage, such as losing a job or changing a job, young adults who's aged out to be covered by their parents, working multiple part-time jobs, working as a gig worker, a contractor, starting their own business, or signing on to a spouse's plan. So our online survey was available for the first time in English and Spanish, and we conducted it the last 2 weeks of August, and we had 712 completes for Marylanders, so pretty high rate of people polled. And thanks. The market research, as you can see here, most experienced a specific employment circumstance that can impact health insurance, change jobs, or many were either currently uninsured or recently uninsured, and most had faced a general financial challenge. Those included, let's see, many also opted to start some opted to start their own business. We asked them a little bit more about the financial challenges, but most of them had to cut their budget, put off vacations, making major purchases just to pay for healthcare costs. And then, so younger Marylanders, no surprise that they are more willing than the older to go without health insurance. And we even asked them for what period of time. 1 in 5 were willing to go without insurance for more than 6 months. And most said that health insurance was a protective service compared to a transactional service. And I'll explain that in a minute, but they're willing to go, they're somewhat willing to go without to apply to fill a gap, but nearly all could be motivated to get insurance. A lot of them didn't re-up right away because they wanted to save money. They wanted to be encouraged to apply by someone they trust. And also they needed assistance for the phone, by phone or online. And they also had seen advertising that would prompt them to get health insurance. But the majority of these have said that they were waiting on a job offer, or they couldn't afford it. They were healthy. As you know, we call this audience the young invincibles. So they think they don't need it. And some of them are actually waiting to get sick in order to get insurance because they don't understand how that works. Next slide, thanks. So we did message testing as we do every year. And we use this to inform our marketing campaign. So the most popular messages we had were the second message here, that every plan, what do they cover? And a lot of people aren't aware of those essential health benefits. And so we've worked those into the copy, covers doctor visits, emergency care, prescriptions, and mental health, among other things. And someone replied that as someone who suffers with mental health issues, she likes to see companies who are in the forefront of that. And then the other message that we used last year and we're using again this year pretty much was life happens. Maryland Health Connection could give you a sense of security and stability when parts of your life may feel unpredictable. So especially this year, you'll see in our campaign where all these things are happening around you, but to get health insurance through Maryland Health Connection is an option when you experience a life changer when it's open enrollment. So after hearing of these messages, about 6 in 10 were more likely to visit Maryland Health Connection. So about half of the target audience had already sought information from Maryland Health Connection, especially the lower income groups in the capital and central regions and African American and Hispanic residents. For most, Maryland Health Connection was familiar and had already been used among some of these Marylanders, and they found out about it through online searches and engagement. The majority of these are people who are getting and losing jobs, or maybe they have a spouse who is, or have gone through other life changes, so they're rolled off and then they come back in. So 60% of this audience has enrolled through us before. So I just wanted to does anyone have any questions about the research before I move on to the events? You all, I know, got a copy, and if you'd like to know more about it, you can take a look at the slides and reach out if you have any questions. I know it's a lot of information to distill here. So I'll move on to the events we have planned. We have a Hispanic roundtable. Can you go back one, Cynthia? Thank you. That's actually tomorrow morning from 9 to 10:30 a.m. It's a pretty small group of Hispanic community leaders. There are about almost 70 people coming, and we're having speakers from Delegate Pena Melnick is going to speak, and a leader from the Maryland Department of Health, as well as Michelle, are speaking tomorrow morning at Montgomery College. You're invited if you have the time. And I know Michelle sent an invitation. You could still RSVP if you're interested. And then we're having a big, instead of just having a regular press conference on November 1st, we chose to partner with Waterfront Partnership and some of our fitness influencers, as well as a radio station personality, make it more of a media visual event. So that'll be from 5:30 to 6:30 at the Inner Harbor. And then we're also doing some community outreach activities. Some of the consumer assistance organizations are doing them with us. We already went to the Maryland Association of Nonprofits Conference and the Central American Festival. And then we're also going to the Maryland Rural Health Conference, Hispanic Business Conference, the Great Halloween Lantern Parade. We're going to be the sole sponsor of that, so we're excited about that. And also at the Baltimore Zoo, we're participating in Zubu for a weekend. So our media buy this year, as Andy said, we're mirroring the same target audience. We did gear it to 19 to 37 this year. It says 34, but that reflects the young adult subsidy age being raised as well. We've started to run ads already, and they will go through January 15th. We've set aside $2.3 million of our budget to advertise for open enrollment. What's new this year? We have a digital mobile billboard It's going to go through the state the first 10 days of open enrollment. It will have messaging. We've spoken with each of the consumer assistance organizations, and we'll either be highlighting an event in that area or just using their information and phone number and directing them to the consumer assistance organization in that region. We realize how important it is to have people who live and work in those areas be handed off to the CEs in case they need face-to-face enrollment or they'd like to go to an event. So that's a new feature we're having. And then we're also printing information on Family Dollar and Dollar General receipts. Here's an example. It's a big coup because a lot of these stores have out-of-state corporate red tape to go through in order to get sponsorship. So GMMB and team worked really hard to get our information on these. So that's a large part of our audience. We also have partnerships with NFL players, including radio endorsements. Geno Stone of the Baltimore Ravens, he did great in the game on Sunday, and then the Washington Commanders players. And we'll have some digital ads on their sites as well. And we're using Snapchat this year. It's a prominent channel for our young adults, as well as LinkedIn. So with that, I will give you a glimpse of our TV spot this year. We did it in both English and Spanish. Can you get the audio, Cynthia? Still can't hear it. I think you had to open it in a separate tab.
I feel terrible today, but I think you may have to stop screen sharing to reshare it again to share your computer sound so that we'll be able to hear it.
Thanks.
Now you can't see the screen if I stop sharing the screen.
No,
Oh.
you just have to reshare it, and there's a
I'll
button
reach it.
that says share computer sound, and you just have to make sure you click that. Thea, if you want to drop the link to me, I can go ahead and share it. Or Betsy.
And I'm getting back when I had logged out. That's what happened. Hold on.
If I may, maybe you can forward it to us and we can see it out after the meeting individually on our own, maybe.
Yeah, or Cynthia, if you stop sharing, I'll be able to share it. Try that. Let me know if you can hear this.
Yes, we can.
Todo está bien. Estoy cubierto. Tengo una cita con el médico esta semana. También estoy cubierto para eso.
Cariño, estoy embarazada.
Estamos cubiertos.
No podemos planificar todo, pero puede tener tranquilidad con Maryland Health Connection.
Let me show you the English also.
All good. I'm covered. Even got a doctor's appointment this week. Covered for that too.
Babe, we're pregnant.
We're covered.
You can't plan for everything, but you can get peace of mind with health coverage through Maryland Health Connection.
So that's the TV spot. We'll have a lot of compatible, the same theme of this person's covered, all this unexpected stuff happened and he's able to handle it. So just everything when life is busy, calm in the chaos, we call it, we're here for you. So does anyone have any questions or comments about that?
May I? In our marketing and outreach, I heard a lot about Prince George's County, Montgomery County, Baltimore City, Ravens, Commanders. One of the areas of challenge has been our rural areas in Maryland. And what efforts are we making in those areas?
We have heavier buys in the rural areas as well as Prince George's, Montgomery, and Baltimore City. We use the meta areas that Tamara showed to inform our advertising where we're going to spend our money. So, the Commanders area hits Prince George's and Montgomery, as you said. We're very active in the rural communities as well. The mobile billboard, as the ethnic papers and the radio is really heavy in those areas too. And we'll be doing cable in those areas. And I didn't break it down that far for you, but we worked with each consumer assistance area to show them where we would be putting our media buy, so they could either eliminate that from their menu, or if they wanted to put more money into the same thing, they could do that as well if they felt like that was the best channel.
And the other part of the question was what kind of efforts we are making with physicians, especially primary care physicians, pediatricians, OBGYN. These are the areas that are much needed by many of the individuals who may have been insured. And also, if we are in connection with FQHC, federally qualified health clinics, that could be another source of reaching to the community that needs help.
Thank you. We do have lists, and we send about 120,000 brochures. They're actually rack cards this year of open enrollment with a QR code leading to our website. And we send those to all the hospitals, libraries, federally qualified health centers, school-based health centers, and even the legal clinics in the courthouses. And also our consumer assistance organizations have those tools to reach out as well.
Thank you.
Any other questions for Betsy? Thank you, Betsy. I think that ends our formal presentations. Are there any questions on anything we've heard today before we wrap things up for the day? There's no closed meeting anticipated at this time. I don't hear any questions about any of the presentations that we've heard today. I want to thank all the speakers for all the information that we heard. Michelle, our next meeting is in December?
January. Our next
January.
meeting will be the third Monday in January.
Okay, well, I'm going to officially close the meeting. I want to thank everyone for their time. And since we won't be seeing each other until January, enjoy your holiday season, starting with Halloween, which is right around the corner. So thank you all.
Thanks, everyone.
Bye.
Bye.